What if persistent high blood sugar isn't only about carbohydrates? What if part of the reason your HbA1c refuses to improve has to do with something much quieter, something happening at the cellular level? Most people with type 2 diabetes focus heavily on cutting carbs, counting calories, or adjusting medication. And while those are important, there's a deeper layer to glucose control that often goes overlooked. Insulin does not work alone. At the cellular level, insulin signaling depends on micronutrients, especially certain minerals, that act as cofactors for enzymes involved in glucose metabolism. When these minerals are deficient, insulin may still be present, but its signal becomes weaker. Glucose remains in the bloodstream longer, fasting levels creep up, post-meal spikes last longer, and over time, HbA1c reflects that instability. What makes this even more concerning is that mineral deficiencies are common and often silent. Symptoms can be vague: fatigue, muscle cramps, brain fog, cravings, poor sleep, slow wound healing. Rarely do people connect these signs to blood sugar control. Today we're going to examine 3 essential minerals that research consistently links to insulin sensitivity and metabolic stability. Magnesium, chromium, zinc. These are not miracle cures. They are foundational micronutrients that support how insulin functions inside your cells. And the third one surprises many people. Let's begin with the first, magnesium. 1. Bark, magnesium, the insulin sensitivity mineral. Magnesium is one of the most studied minerals in relation to type 2 diabetes, and for good reason. It plays a role in more than 300 enzymatic reactions in the body, many of which are directly involved in glucose metabolism and insulin signaling. Here's why it matters. When insulin binds to its receptor on a cell, a cascade of intracellular signals must occur for glucose transporters, especially GLUT4 in muscle cells, to move to the cell surface and allow glucose entry. Magnesium acts as a cofactor in this signaling pathway. Without adequate magnesium, this cascade becomes less efficient. Insulin may still be present, but cellular responsiveness declines. Several observational studies have shown that individuals with lower magnesium intake tend to have higher rates of insulin resistance and type 2 diabetes. Additionally, magnesium deficiency is more common in people with diabetes due to increased urinary loss caused by elevated glucose levels. This creates a cycle: higher glucose room, more magnesium loss, reduced insulin sensitivity, higher glucose. Correcting magnesium deficiency does not cure diabetes, but research suggests it may improve insulin sensitivity and modestly reduce fasting glucose in individuals who are deficient. Magnesium also supports muscle function, reducing cramps and restlessness, vascular relaxation, supporting blood pressure control, nerve stability, sleep regulation, all of which indirectly influence glucose stability. From a dietary perspective, magnesium-rich foods include pumpkin seeds, almonds, spinach, black beans, avocado. For some individuals, supplementation may be considered, particularly forms like magnesium glycinate or magnesium citrate, which are generally well absorbed and gentler on digestion. Typical supplemental doses range between 200–400 milligrams of elemental magnesium daily, though individual needs vary. Important precautions: high doses may cause diarrhea or gastrointestinal discomfort. Individuals with kidney disease should not supplement magnesium without medical supervision. Magnesium can interfere with certain antibiotics if taken simultaneously. The key takeaway: magnesium supports the efficiency of insulin signaling. When levels are adequate, glucose regulation may improve, especially in those who were previously deficient. Now let's move to the second mineral, one that directly enhances insulin receptor activity: chromium, the insulin receptor amplifier. Chromium is a trace mineral, meaning your body needs it in small amounts, but its role in glucose metabolism is disproportionately important. Unlike magnesium, which supports broad metabolic pathways, chromium works more specifically at the level of the insulin receptor. When insulin binds to its receptor on the surface of a cell, that receptor must activate properly to send the signal inside. Chromium enhances this signaling process by helping activate a small protein complex, sometimes referred to as chromogulin. Think of it this way: insulin is the key, the receptor is the lock. Chromium helps the lock respond more efficiently. When chromium levels are low, insulin signaling can become less effective. The body may compensate by producing more insulin, which contributes to hyperinsulinemia and eventually insulin resistance. Several clinical studies have evaluated chromium supplementation, particularly chromium picolinate, in individuals with type 2 diabetes. Some trials show modest improvements in fasting glucose and reductions in HbA1c, particularly in individuals with poor baseline control or suspected deficiency. However, results are mixed, and not every individual responds the same way. What is consistent is this: Chromium appears to enhance insulin sensitivity in certain populations, especially when intake has been inadequate. Chromium may also influence carbohydrate metabolism, lipid metabolism, including triglycerides, appetite regulation in some individuals. Dietary sources of chromium include broccoli, whole grains, green beans, egg yolks, nuts. Because chromium content in food can vary depending on soil conditions and processing, intake can be inconsistent. Supplemental doses often range from 200 to 1,000 micrograms daily in research settings, though most over-the-counter products provide 200 to 400 micrograms. Precautions: very high doses over long periods may stress the liver or kidneys. Chromium may interact with insulin or glucose-lowering medications, potentially increasing the risk of hypoglycemia. Always monitor glucose carefully if introducing supplementation. Chromium does not force glucose down, it supports how insulin works. Now let's move to the third mineral, one that plays a critical role inside the pancreas itself: zinc, the pancreatic and antioxidant protector. Zinc is often associated with immune health, but its role in glucose metabolism is deeper than most people realize. Inside the pancreas, zinc plays a structural role in how insulin is stored. Insulin is packaged in specialized cells called beta cells. Within those cells, zinc helps stabilize insulin in a crystalline form so it can be stored properly and released efficiently when blood glucose rises. When zinc levels are inadequate, insulin storage and secretion may become less organized. Over time, this can contribute to weaker post-meal insulin responses. But zinc's role doesn't stop there. It also influences insulin signaling at the cellular level and supports antioxidant defense systems that protect pancreatic tissue from oxidative stress. Chronic hyperglycemia increases oxidative damage. Zinc is required for the function of key antioxidant enzymes such as superoxide dismutase. These enzymes help neutralize free radicals that can damage blood vessels, nerves, and pancreatic cells. In other words, zinc supports both insulin production and protection against glucose-related damage. Several studies have found that individuals with type 2 diabetes often have lower circulating zinc levels. Some clinical trials suggest that zinc supplementation may modestly reduce fasting glucose and HbA1c in certain individuals, particularly those who are deficient. Zinc also contributes to wound healing, immune response, skin integrity, taste and appetite regulation. From a dietary standpoint, rich sources of zinc include oysters, beef, pumpkin seeds, chickpeas, eggs. Supplemental zinc is commonly taken in doses between 15 to 30 milligrams daily for maintenance. Higher doses should only be used short-term under supervision. Important precautions: excess zinc can interfere with copper absorption. High doses may cause nausea or stomach discomfort. Zinc may interact with certain antibiotics if taken simultaneously. Balance is critical. Zinc does not act as a glucose-lowering drug. It supports the biological systems that regulate glucose over time. Now that we've covered the three minerals, let's connect the dots and discuss how they work together. How these three minerals work together to influence HbA1c. Now that we've examined magnesium, chromium, and zinc individually, it's important to understand something critical. They don't work in isolation. Glucose regulation is a multi-step process. First, insulin must be produced and stored properly. Zinc plays a role here. Second, insulin must bind effectively to its receptor. Chromium enhances that signaling. Third, the intracellular cascade must function efficiently so glucose transporters can move to the cell surface. Magnesium supports that pathway. If any part of that chain is weak, glucose clearance becomes less efficient. When glucose remains elevated repeatedly, even slightly, HbA1c begins to rise. Remember, HbA1c reflects the average glucose exposure over approximately 3 months. It does not respond to a single day or even a single week of change. What these minerals potentially influence is daily stability. They may help reduce prolonged post-meal glucose spikes, subtle fasting elevations, insulin resistance progression. When daily glucose variability improves consistently, HbA1c can gradually decline over time. But here's a crucial point. Minerals are not substitutes for medication. They are not replacements for dietary strategy. They are not cures. They are supportive cofactors. Their impact tends to be most noticeable in individuals who were previously deficient. If someone already has optimal magnesium, chromium, and zinc levels, additional supplementation may provide minimal benefit. However, in those with suboptimal intake, which is common due to modern dietary patterns, correcting deficiencies may improve metabolic efficiency. There is also a broader pattern to consider. Ultra-processed diets are typically low in magnesium. Refined grains reduce chromium intake. Soil depletion affects mineral density in vegetables. Chronic stress increases magnesium excretion. Elevated glucose increases urinary mineral loss. This creates a scenario where deficiency quietly worsens insulin resistance over time. Supporting mineral status may help interrupt that cycle. But the most important strategy remains foundational: whole foods, balanced macronutrients, physical activity, sleep quality, medication adherence when prescribed. Minerals enhance the system, they do not override it. Now let's talk about how to approach this safely and intelligently. How to support these minerals safely and avoid common mistakes. When people hear that certain minerals influence insulin sensitivity, the first instinct is often, should I start taking all three immediately? Not so fast. The smartest approach is assessment before action. Whenever possible, discuss mineral status with your healthcare provider. Serum magnesium, zinc levels, and overall metabolic panels can provide clues, though it's important to note that blood levels don't always perfectly reflect intracellular stores. Even without testing, the first step should always be dietary improvement. Whole foods provide minerals in a balanced matrix, alongside fiber, antioxidants, and phytonutrients that support overall metabolic health. Prioritize leafy greens, nuts and seeds, legumes, seafood, lean meats, whole minimally processed foods. If supplementation is considered, start conservatively. Common evidence-informed ranges include magnesium 200 to 400 mg/H daily, zinc 15 to 30 mg/H daily. Higher doses are sometimes used in research, but should only be taken under supervision. Now let's address common mistakes. Taking high doses immediately. More is not better. Excess magnesium can cause gastrointestinal distress. Too much zinc can suppress copper absorption. High-dose chromium over long periods may stress the liver in susceptible individuals. Bartone. Grest and common people tadet de corbu, magnesium and narg presnat nargapregraph and partalprian eruptically. Branuation amilgi is a seed replacement for lifestyle. Supplements cannot compensate for ultra-processed diets, sleep deprivation, chronic stress, or sedentary behavior, expecting immediate HbA1c changes. HbA1c reflects a 3-month average. Any improvement requires consistency. Think of minerals as metabolic support tools. They optimize the environment in which insulin works. They reduce friction in the system. But sustainable glucose control always depends on the full picture. Now let's bring everything together. The bigger picture, restoring the foundation of glucose control. When we talk about improving blood sugar and lowering HbA1c, the conversation usually centers around carbohydrates, medications, and weight loss. And while those are critical factors, the biochemical foundation of glucose control is often overlooked. Insulin does not act in isolation. It relies on enzymatic pathways, receptor signaling, intracellular transport systems, antioxidant defenses, and proper pancreatic storage mechanisms. Magnesium, chromium, and zinc each contribute to one or more of these processes. If we zoom out, we see something important. Type 2 diabetes is not only a disease of excess sugar, it is also a disease of impaired cellular communication. Glucose is present, insulin is present, but signaling becomes inefficient. Supporting mineral sufficiency helps restore part of that communication. Magnesium improves intracellular signaling efficiency. Chromium enhances receptor responsiveness. Zinc stabilizes insulin production and protects pancreatic cells. Together, they help optimize the environment in which glucose regulation occurs. However, none of these minerals override chronic caloric excess, high ultra-processed food intake, severe sleep deprivation, physical inactivity, unmanaged stress. They are supportive, not substitutive. The most meaningful improvements in HbA1c occur when mineral optimization is combined with balanced nutrition, adequate protein intake, high-fiber foods, regular physical activity, sleep quality, medication adherence when prescribed. Another important concept, deficiency correction tends to produce the greatest benefit. If someone is deficient, restoring normal levels can improve metabolic efficiency. If someone already has optimal status, supplementation may produce minimal change. That's why personalization matters. The goal is not megadosing. The goal is sufficiency. Over weeks and months, small improvements in fasting glucose and post-meal stability can translate into measurable reductions in HbA1c. Not dramatic overnight drops, not miracle transformations, but steady physiologically grounded improvement. Now let's close this properly. If your blood sugar has been stubborn, if your HbA1c feels stuck, if you've cleaned up your diet but still struggle with stability, it may be time to look deeper. Not for a miracle supplement, not for an extreme protocol, but for foundational support. Magnesium, chromium, and zinc are not trends. They are minerals your body relies on every single day to regulate insulin signaling, glucose transport, and cellular metabolism. When levels are adequate, insulin communication improves. When communication improves, glucose control becomes more efficient. And when daily glucose variability decreases, HbA1c follows over time. But remember, supplements support lifestyle drives, consistency wins. The smartest strategy is simple. Eat whole mineral-rich foods. Test and monitor when possible. Supplement cautiously if needed. Work with your healthcare provider. Track trends, not single readings. True metabolic improvement is not about forcing blood sugar down. It's about restoring how your body is designed to regulate it. If this video helped you understand the deeper layer of glucose control, subscribe for more evidence-based guidance on type 2 diabetes, insulin resistance, and long-term metabolic health, because control becomes possible when you understand the system.